In our increasingly connected world, we are digitizing and centralizing medical records. We're changing the way we make doctor's appointments. And companies like ZocDocs and Surescripts are trying to change how doctors and patients engage with one another. The question is, how's it going? So to talk about that, I'm delighted to welcome the president and founder of ZocDoc, Dr. Oliver Kharraz, Executive Vice President and General Manager of Surescripts, David Yakimischak, who says, call me Yak, thank you. And Senior Vice President of the Lown Institute, Shannon Browlee. Shannon has written for The Atlantic, she's written for the New York Times, and many, many other publications. She's also the author of the book, Overtreated: Why Too Much Medicine is Making Us Sicker and Poorer. And leading the conversation, my colleague, Washington Editor-at-Large, Steve Clemons.
Great, thank you so much, Margaret. Come on in, up, folks. Hey, is Rachel Kalmar here? Rachel, where are you? There you are. Stand up. Everyone, I'm doing this for a point. You're going to see Rachel later. Just kind of give them a sense, shake a little bit. She's got every we did an article in The Atlantic years ago. Come on, have a seat. We did an article years ago called The Most Measured Man. This has got to be the most measured woman. And glad to have you both here. But we're going to talk to Rachel a bit. But I'm going to mention, because you may see me buzz every once in a while, because I'm wearing a Numitra stress meter watch here, which I've never done. And when I'm in a high stress moment, it jolts me. And then it makes me stressed out. But you know. So we're going to talk a lot about that later. But I just want to point out, Rachel, you've just taken it to new limits. She's got every gadget out there. Who knew? So we'll be back. But thinking, about technology and what it's doing to the health world, both positively and negatively. We've got a great panel here, and I guess I would just start out, with one provocative question, and I want to ask my old friend. Years ago, we were together at the New America Foundation, Shannon Browlee. You wrote a piece basically saying CVS is essentially destroying America's health, because you were making a claim that primary care physicians and that human interface was something that we needed to preserve. And I thought this was Shannon Browlee at her most anachronistic. And I'm just sort of interested in this world where technology is bringing us so much, why are you clinging on so desperately to the human dimension? What is important there?
Well, this is Steve being at his most provocative and exaggerating. I did not say they would destroy America's health. I said that they were going to destroy primary care if primary care didn't respond. And CVS is responding to a real need, which is that people don't need their doctors just between 9 and 5 on Mondays through Fridays. They need their doctors earlier in the morning before their kids go to school. They need their doctors in the evenings. They need their doctors on
So why don't you tell us what CVS is doing?
They're doing things that are basically minute clinics, which most people
They got rid of cigarettes and they said we're going to have,
Right. So, and why is this hard on primary care? It's because primary care works on the volume of visits still, which is insane. That's why doctors see 30 patients a day, even though half of them don't need to be there. It's because their business is based on getting patients in and through their offices. So what CVS is going to do effectively is skim off the healthiest patients, which are the ones that you can run through your offices the fastest. The patients that take the most work are your chronically ill, and those are the patients that really need to see primary care. But in a fee-for-service model, that means you have only your sickest patients left, and they take more time. And primary care is really going to struggle. But the other piece of this has to do with your second part of your question, which is why am I clinging to the human dimension? Because people who are sick need more than technology. People who are sick need to be healed. And healing is partly spiritual. It has a lot to do with that human connection. And if we destroy that, we will have destroyed one of the really deeply, fundamentally important pieces of what medicine is all about.
Let me jump to David. Actually, it's Yakimischak, and we're going to go by Yak, which is at your request. So Yak, in this human dimension, one of the things we did at the Atlantic last year was an event that was underwritten by Siemens, and we had Siemens share with us a study that they had underwritten that I've subsequently checked. That is that the level of misdiagnosis in our health system is staggeringly high. It's around 35 to 40%. And so again, in a friendly way, when you look at this, the application of technology and how you're really a pioneer in sort of looking at the issues of creating a patient-centered using data to create a patient-centered set of opportunities. What does that do in this world of misdiagnosis and what I would probably recklessly characterized as the human variability problem in healthcare.
Well, I mean, I don't come from a position where technology is going to solve the problem and give the correct diagnosis. I mean, I come from a position where we're at right now, which is we should be using the technology to take away the routine, to take away the mundane. Some people call it the commoditization.
The routinized parts.
Yeah, I mean, let's talk about the commoditization of healthcare. There's some parts of that would be very bad. I think there's some parts of it that would be very good and could make a lot more efficient system, such that we have more time and resources to put into doctor-to-patient time. Mm-hmm.
So if CVS skimmed off the top and took all the easy cases, wouldn't that leave more time and attention and resources in the system to deal with people with a chronic?
Well, it would, but I think we've heard that it's the underlying economic structure that causes a problem then, because the skimming, so to speak, takes away the profit, is really what you're talking about. It takes away the profitable patients and leaves you with the expensive ones. That's not a technology or a business structure problem. That's an underlying economic issue that the most expensive people are those who need the most care and who typically are having the most trouble getting it.
So you're in this business. You make money. Are you guys public? Do you have stock?
No, we don't make money. We don't make money.
You're a nonprofit.
So we're a startup. We lose money.
My goal is not money.
My goal is
the
actually
health of the world.
My goal is literally to reduce our revenue and to reduce our cost.
So there need to be no more Atlantic healthcare forums in the world. I think the question of putting yourself out of business is sometimes a useful one to sort of frame what the challenges are. How do we come together every year? This is our 7th year, and kind of look at some elements. And I tell you, from the time we started this 7 years ago, and you sort of look at what we've been talking about year to year. The technology, we've not gotten to all of her yet, but in the arena of what is available to people, 250,000 plus health apps on their iPhone or digital phones and whatnot. When you look at, however, the inertia in the system, the inefficiencies in the system, they're still profound. And I just want you give me your nastiest critique of the healthcare world as you see it.
Well,
what's not getting fixed?
Well, being a Canadian.
Okay.
Can I start there?
Go ahead.
How many people in this country?
I liked you.
How many people in this country don't have access?
Yeah.
I mean, to me, that's a fundamental, but that's not mine to decide. That's just my observation. If in this country, if you get sick, it could destroy your life, and that doesn't happen north of the border. So if you asked for number one,
so that's number one. What are 2 and 3, since that's sort of a biggie and obvious? But I mean, tell me how data and we're talking about data and how it's revolutionizing or changing. What patients can do in navigating this health architecture.
The potential is tremendous, and that's why I'm in the field. I mean, I'm a technologist, and I think that the application of technology to healthcare has incredible opportunity and a long, long, long cycle to go. We shouldn't look at it as the silver bullet, but it can help, and it can take out waste, take out cost, and improve care. We are not taking advantage.
Now, are hospitals your friends or hospitals your enemies?
They're our friends.
They're your friends?
Yeah.
Are they your friends?
They're my customers.
They're your customers. Okay, you have to be. Yeah, okay.
Yeah.
No, I ask that because people like Jonathan Bush out there with Athena are saying they are keeping America from being a far healthier place. I'm probably putting inappropriate words in his mouth.
They, the hospitals.
The hospitals act like fiefdoms in a feudal world, not sharing information. That the problem with data is that data needs to be migrate. It needs to be shared. You need to look at patterns over large swaths of population. And once you see that, you can do things with health to apply big data at the individual level. And he says hospitals are the ones stopping that from happening.
Isn't that everybody in the system stopping it?
Yeah.
Can I just offer one observation? Because we have been talking about this for 7 years, as you say, and I think one of the...
Were you here 7 years ago? You were probably...
I was taking your word for it. 7 years ago, I started my company.
Yeah.
But one of the interesting things that has been pretty much a constant as we're talking about it is that we always talk about the system. We talk about, what is CVS doing? What are the primary care doctors doing? What's the data that we can collect about the patient? maybe it's worthwhile asking a completely different question. Because like, what is the reason that a CVS can open this? They're responding to a patient need. There are patient behaviors. And why do patients do that? Because if you go to your insurance directory, you start dialing down the numbers that are there. First of all, 50% are going to be inaccurate, which upsets you and maybe makes you more likely to go to a CVS. The second thing is you will get your first appointment on average 18.5 days out. Well, at which point it makes it so much more attractive to go to a CVS. And so if we don't have the patient lens on that, we will never be able to actually change the single most important factor in our healthcare system, which is patient behavior, right? And so to do that, we need to use technology to enable new behavior. So you go to ZocDoc, you can find a doctor within 3 days. That's wherever we go. Most appointments happen within 24 hours. I challenge you all to
I just downloaded it, and I was looking for somebody to help me with my stress and sleep and this thing, and I've got somebody willing to see me now. So thank you.
And I'll invite you all to put my words to the test.
Now, does ZocDoc work in Europe? Does it work in Japan? Have you gone international yet? Or is it just a U.S. thing?
We're currently, my hair is turning gray over the U.S. And I think it's a universal need, but I do think that getting one system right is worthwhile. And as you can tell from my accent, in the U.S. by choice, I want to contribute to the society that took me in.
But it raises a question, because he was just basically lambasting the American healthcare system from his Canadian perch. Is it in the data and technology arena? Is it a more dynamic environment in the chaos of the American healthcare system to innovate, or is it better to be in a Canada or better in a Europe that maybe generate higher coverage? But I'm sort of interested in the innovation environment. Is the chaos and craziness here, does it help you guys?
Well, ask the question, better for whom?
Yeah.
And I'd love to hear the answer, but I'd like to hear the better for whom piece.
So better for whom, and in terms of the innovation space, which if you presume that innovation space eventually makes all boats rise. Is the U.S. a better place to be, or is it Europe or Canada?
Well, if you want to comment it from a systemic level and say, hey, by fiat, this is what's going to happen starting tomorrow. Of course, you're much better off, being in a European or Canadian-like system. I was in Germany for the introduction of their version of meaningful use, and you know what? It worked like this because you wanted to get paid anything, you had to adopt one of 3 systems, and that's that. And you can do that. We don't. Is, I think, wrong. And it's underutilizing the new level of technology we have. Because to get back to that big data piece, I don't think it's about measuring more things about the patient and like trying to collect more data and second guess our clinical studies with that. The point about data is that we now have the opportunity to close the loop on the patient behavior, which actually means that we can go do what evidence-based medicine has done for us in the 20th century, understanding how certain molecules change our metabolism, to understanding how certain messages change our motivation, and how it changes the way people act. And if you think about chronic disease and the things that will make healthcare unaffordable potentially in this country, it is based on people's choices. It's not that we don't have an understanding on how to treat these conditions. It's that we don't have a good understanding of what I need to tell this patient for them to actually do it, and what I have to tell this other patient. And I remember when I was going through residency, it's something that I learned as an apprentice, as an art, from good attendings. I say, like this guy, he really cares about his family. Talk about that will make him move. This person is very competitive. Let's tell him that everyone else is doing this. And what we need to do is we can actually now measure. We are communicating with millions, tens of millions of patients every month. We send them emails saying, here's a preventative thing that you should be doing. Like, we can send different messages to different people. And we can say, great, how do I communicate with a 25-year-old male versus the 35-year-old mother of 2? Going on in your body? Should I tell you the bottom 3rd percentile of the population, get up your ass and do something? Like, there are different ways to say, to nudge people to do the right thing and what we understand to be the right thing. Yeah. And as long as we don't ask these questions,
Can I put a slightly different framing on that?
Let me just ask him one question and then come in. But of course, but you, just on this point, you fill 1 billion prescriptions annually. So you sort of see the world. You're like God, right? You see
Well,
everything happen. What are the patterns? I mean, this issue of people getting prescriptions but not taking their drugs or not, you know, how do you...
Well, that's what this opportunity provides. And what I was going to say is I think there's a couple of worlds here that aren't getting connected. And the agenda around health IT and the investments, and there is tremendous innovation and tremendous investment, happens to be right now around what I'll call the industrial complex of healthcare. You know, the hospitals, the pharmacies,
These are your friends, the hospitals.
Our friends,
yeah, the
absolutely.
industrial
there's a whole world of...
There's a negativity associated with the industrial complex, right? Or you're embracing it.
It is what it is.
Okay, great.
Yeah.
Okay.
It's the world of consumer, and by the way, that's you and me, right? We are getting connected. We're trying to provide care for elderly people who can't take care of themselves. We're doing things the best we can. We're trying to navigate the system, and the investments of technology are not being connected. You know, they're each trying to figure out their own world, and I think the agenda needs to include how do we bring these patients and their technology, but how do we bring the patients into this discussion and have them drive?
Shannon, different frame.
I guess the slight difference I would put on the framing is that we're putting this in terms of doctor or clinician and patient interaction, and how do you get patients to change their behavior?
Right.
But if our goal is health rather than health care, and we should have both goals, so we should have a better healthcare system, but really what we all want is a more healthy nation. If what you want is a healthy nation, we have to acknowledge that most of what drives whether or not people are healthy or sick doesn't happen in the hospital. It doesn't happen in the interaction between clinician and patient. It's really what goes on in communities. And my problem with much of the way we're framing...
So we need a whole health care.
We need a health system.
Yeah.
And the thing is what we're doing right now is we're putting all of our money, I mean, huge proportion compared to other countries, of our money into health care, and we're starving the things in communities.
So you're on Mike Bloomberg's let's ban sodas and snacks.
Yeah, that's a little teeny piece of it, but another piece of it is how do we take care of the elderly in this country? We spend huge amounts of money, not just on dying, but on the long slope downwards, where people become increasingly frail, demented, unable.
Are you advocating cutting them off?
No, I'm advocating that we care for them in communities, which is not only less expensive, but it's where people want to be. Silver cities?
What the Japanese call old age kind of communities.
Maybe.
Silver city, yeah.
Maybe, although I'd really rather stay in my home, thank you. So this idea that health is all on the individual, that you know, percentage of our population that doesn't have access to safe streets, good food, good schools, etc., and good care at the end of life. That's going to hit all of us, by the way, except those who are the wealthiest and can move into these very special places that are $3,000 to $6,000 a month. Now
unless you've shifted, for a long time have been the advocate of less is more, that we overtreat, that we have a system that's basically corrupt, and the corruption is on the side of money-generated therapies, which doctors and hospitals and insurance, and you said we just need a lot less of that. How has that campaign been going?
Very well, actually.
Yeah?
There's a huge number of physicians and nurses who are deeply dismayed. Are there any clinicians in the audience?
Tons of them, I think.
So
yeah.
You may be a selected population if you're here listening about technology, but there are thousands of nurses and physicians who want a better system. They want time with their patients. They want to return to a system that really sees it as a moral obligation, not just a business. And I think I'm sitting on the stage with people who are on the business side, yet see that side of it as being really fundamental.
If I may build on this. So, you know, point when you are a clinician is actually that patients are asking for these things. And it's interesting, there was a great article in The Economist a few years ago about how the rate of antibiotics resistance and inflation in countries is highly linked, because it's the same thing. Can you actually resist the temptation to do the thing that seems to be helping somehow in the short term, which is whether it's popping the antibiotics or
prescribing it because it's easy
or
because it gets the patient out of your office.
There is a societal a mentality thing to it. And in the US, the general thinking is more is better.
More is better.
But the reality is the only way how you educate people about that is at the point of care. And it needs to be, when the decision is to be made, they need to be knowing what actually weighs against it. It needs to be shared with the patient in a way they can understand. And today, too many things that are out there for the patient to consume, and there are great resources out there, big data, what have you, but they're presented in a way that the patient can make heads or tails of it. And that's where I think actually seeing how we present things to patients and what is sort of the mental map that they use when they approach healthcare, that's sort of the next wave, because otherwise we can, the experts in this room can come up with better and better, more sophisticated and arcane insights that are completely meaningless because they're never translated in actual behaviors and never translated in what the patient is asking for. And that's where using technology can be a great tool for us because it comes back to evidence-based messaging and understanding what the patient actually.
Let me ask you a question about ZocDocs, because I was just playing, I really did look for a doctor who could help me with my sleep and stress. And I found 4 recommended people just in this area, all of whom were available today. One of them had 5 stars, and the other 3 had 4.5 stars. How many people have used ZocDocs? So they've got 6 million users. I think a substantial number of them are here. And I think that in that, it occurred to me that the 4.5 stars, it's kind of like an Uber driver. It skewed so high that if you, maybe for a premium service, you have between 1 and 100, right? So you're able to, and I'm interested in what actually, if all doctors get in this, don't you end up seeing a migration to the very best and a defection from the very worst, and you get a winner-takes-all system within the world? I mean, I'm sort of interested in the skewing effects, whether you basically end up having, the rating service can be very good, but you can actually, create some interesting pressure points that didn't exist previously within the system, and whether that's good or bad.
Yeah, so happy to engage with that. So, the reviews, we are the only closed-loop review system, that separate from the doctor, separate from the doctor's staff, or from the doctor's competitor.
So you can't game it.
You can't game it, right? And then the second thing is we ask all the patients that book with a doctor for their opinion. So it's not only the outliers that have in healthcare typically extremely bad experience that leads them to leave a review. So you get these reviews, and I would say they are overwhelmingly positive because most patients.
Do the doctors get to rate the patients like Uber drivers?
No, they don't.
They don't.
No, they don't. And I don't think doctors.
That's in the record.
But the point is actually. So there are the star reviews, and I think they are obviously a corrective mechanism. But there are also prose reviews, and all of these reviews are read by human beings. I used to be one of them, and so many years ago, I read this review about one of our dentists, which said, it was a 2-star rating. That I'm never going back to this dentist. Horrible experience. Came into the room, did whatever they did, didn't say a word, just walked out again. So it was like a little bit robotic experience. And I thought, oh my God, this dentist is done. Like there will be no additional patients. Well, it turns out I was completely wrong. There's a population that doesn't like one-sided conversations and says, great, when I'm in the dentist chair with all these utensils in my mouth, I don't want them to talk to me because I can't answer. And so, I want that dentist. And I think what it does is actually it selects the right patient with the right doctor. It creates this click. This connection that ultimately helps the doctor to get cooperation from the patient, to go through the phase where the prescription maybe has more side effects than actual benefit, and go through with it. And trust me, it takes 4 weeks for you to see the benefits. Go on taking it, because I understand if you do it, you will be better. Like I need to have your trust. I need to have a relationship with you. to give me license to ask you that. And how do I do that? By being the kind of person that you like to form relationships
I mean,
with.
I don't like doctors.
Humanist.
Yeah.
Humanist.
I know, but I'm perfectly comfortable with a machine. We were just joking about this, but I'm actually, my partner is really into sort of talking with doctors and dentists and having relationships with them. I want to know as little as possible.
So that dentist might be great for you then.
Yeah, I totally am going to go for the 2-star dentist. But yeah, I mean, when you think, you know, when we're thinking at breakfast this morning about the challenge of thinking forward, let's transport ourselves 10, 15 years ahead. What are the questions we need to be asking today to get that 10 or 15-year jump right? What are we missing in our conversations about tech and health? I mean, maybe it's silly to dismiss the human dimension as I am, but I'm sort of interested in, you know, getting a much whole health system along the lines that Shannon said, and how technology takes us there, or maybe technology doesn't. But jump transport. Thinking about your business 10 years from now, what have you done for us to fix our problem?
Well, but the questions I would be asking now is, do we have the right policy forums, groups, organizations, decision makers, and incentives, value thinkers, those kinds of thinkers in place? Because, you know, we had to invent our network 10 years before it got to where it is.
Right.
And there were some visionaries who got that set up and got it on the right footing such that we could get to this point. We need that kind of thinking now, those, whether it's visionary, policy, all of the above, economics, to get ourselves on that trajectory.
But who are the bad guys in the process who are impeding progress?
I wouldn't single out a bad guy, Steve. I'm not going to take
Trying to get that tweetable moment.
I think we're all you know, the famous we're all the problem. I mean, I am the problem. Is that I don't think we have a national consensus and a national momentum to solve. We can't solve everything. I mean, one of the things I was thinking as this was going around was, one of the early lessons I learned in computer science was, don't try to automate a mess, because you're just going to make it faster, more efficient, and get it wrong more quickly.
Better mess.
Right. So if we have this idea that we're going to just lay technology over a system that isn't figured out yet, and that it's going to solve the problem, there's our problem. Yeah. But so we are solving, and technology is solving problems. I mean, every day you hear them, but they're solving them in small ways, in small places. I found that the national level needed that kind of momentum, because where technology really works is at scale. You get 6 million people.
What's your list of bad guys?
Okay, so who am I?
Right.
You're a doctor. And this, how many of the doctors, raise your hand if you're a doctor or a nurse, how many of you love your electronic medical record system? So, yay, you must be at the VA.
Are you VA?
Wow.
So electronic medical records are a fantastic notion. They are going to be very important, but the way they are being applied is to basically, as Yak says, applied onto a dysfunctional system right now and saying, oh, let the market sort it out. To me, the way we're going to see healthcare evolve is using technology in the right way, but that means we as a nation have to ask some much more fundamental questions. Do we want healthcare to be just another business, a commodity, or do we see it as a common good? And I think the way to get there is what we're trying to do at the Lown Institute, which is we are starting to go into communities and getting communities to engage around these questions, because this has to be a democratic process. Healthcare right now doesn't involve the community in a way that is real, that gets at what the community really needs, what the community really wants. And since it is we, the people who are paying vast sums of money for it, we should have more of a say. So I think we've got to to first answer this really fundamental question about whether or not we want it to be a common good or not. And the way to get there is through a democratic process.
Thank you. Let me open up to the audience and take a few questions. Do we have mics out here? Yes, great. Comments, reactions, alternative, our VA guy, do you want to defend yourself?
There's nothing to defend.
Yes, right over here in the middle, in the back.
Oh, I'm sorry.
We'll go to either one of you.
Thank you.
Yeah, go ahead. Yes. I want you to stand up because it's better theater.
This is just a kind of a suggestion in the form of a question. We call the patient, or sometimes client. And I was wondering if we could change that words. There's been a lot written about the active patient, but how about calling the patient participant so they participate in their health? Would that change the interactions in any way?
Shannon, that sounds like a humanist question.
The word patient comes from the word to suffer. We could call them participants. It might change, but really it's the action. It's the sharing of decisions that's so crucial that is embedded in what you were talking about. Is this need to use technology in the ways that increases communication and increases the transmission of information and knowledge.
And really,
Oliver?
I might even want to call him the driver. Like that's what I
call your constituents drivers?
No, we do call them patients because it's the generally accepted word, and I have a long theory on the English language. But
in German, are they drivers?
No, in German they're not drivers either. I think that's a more recent development, honestly. Like people have come to expect that they are self-directed, that they're self-controlled, that they have the transparency in all other aspects of their lives, right? And so as long as we're trying to solve the healthcare system and pretend that the entire world around us hasn't changed and that consumers haven't changed their expectations because this is so isolated that the rest of their life doesn't influence them, and the fact that they could do everything self-controlled on the internet with their mobile phones doesn't reach into this part of their life, that's just closing your eyes to a reality, right? And so patients, we all have been trained that every aspect of our life we can get delivered to us, we can make a decision on, that we are an actor in this game. Healthcare is exactly the same. We're kidding ourselves if we think that we can create a system that it's about setting the right policies and that it's like a top-down decision, like in an army where we're going to tell people what's going to happen, and that leads to this positive campaign where we ultimately conquer the enemy that is cost. That's the thinking that is exactly getting us into the problem that we're in today. Like what we need to actually saying, great, our playing field has completely changed. People that we could just be assertive to, tell them, hey, here's the recommendation, now go do it. These people may exist. They're not what's driving the healthcare system of tomorrow. And so we need to deliver the tools to that next generation of healthcare participants that have very different expectations and that want to be setting that driver.
Buzzed.
Maybe we're all, we started with Canada.
This is a bad device for you, Steve.
No, I should be in blue.
Get rid of this.
Did your stress just go up because we're running on deadline?
It did as I listened to Yak. To Oliver. But Yak, thoughts on language?
If I was in Canada, to close that loop, maybe we call ourselves citizens.
Yes.
We're all citizens.
Citizens. Yeah. It's getting I'd call them competitors in a crazy healthcare minefield. But yes, right here.
So I just heard about decisions, but I'm interested in outcomes, particularly related to ZocDoc. It's essentially crowdsourcing, as I see it. But how do you get into that outcomes, really solid outcomes, so that you really know what the decisions that the system, or individual doctors in this case, have made, or patients have made, whether or not they've really had a solid outcome?
Good question. Oliver?
Happy to engage on it. So the reality of math is that no one has actually a really good outcome metric, including us. And it's very desirable, but I don't think it's actually feasible given on the number of patients that any given doctor sees and the variability of the patients that sort of go into their practice. Maybe once we're all diagnosed by algorithms, which I think hopefully is not going to happen very soon, that might be possible. Today it's not possible. So what we do instead is we measure two things. Number one, how well does this pre-meeting happen? Like how well are you likely going to connect to your doctor? And that's based on giving you qualitative reviews on how this person is as an individual and being able to pre-meet them sort of virtually. The second thing is, and we're just starting to pilot that, is that we can actually ask you a few weeks later whether you followed the doctor's instructions. And that will actually help us in the future to suggest doctors to you that pair well with you, where actually you're more likely to go and heed that advice that you spent your time on and your money on to get. And so that's where I would say, the compliance, the cooperation between patient and doctor, that's a very important outcome in itself, because it's the thing that we can really do for the things that are so well understood. And the edge cases where people are getting it wrong, from my personal experience, that is a very hard thing to do, and I've looked at that in the past.
But we can get outcomes for hospitals and for systems.
For large systems, you can totally get outcomes.
Right.
I agree with that.
Right.
But for the individual doctor, just given the numbers of observations you have on either side, it is.
But Athena or some others would say if you had more sharing of these systems across, you would get more outcomes.
On a system level, we already have that information. On an individual doctor level, right? I'm not a statistician, but I got a PhD and I know enough math that if you have a huge variability of the input variables, and a very small n to then observe them, you won't actually be able to say with enough certainty that there is a difference in the actor here.
We'll take the last question from this gentleman. You had your hand up, right? Yeah, you don't be shy. Put it up there, big hand. Stand up. Just make it a really good question. Is it a good question?
Name and organization.
Sure.
Okay.
My name is Dylan Nelson with the National Business Group on Health, and one of the first kind of discussions was about CVS supposedly destroying primary care, and I think
They're probably your biggest member, right?
No.
Second thing.
But I think as we talk to our members, we're trying to help people, citizens, become engaged in the care that they're getting. And if I have a minor health issue, I want to go somewhere that's going to be a low-cost setting of care where I don't have to bother my doctor because I know that she's got patients who need more help than I do. And that the kind of root of all evil in this sense is the incentives, the financial incentives that the institutions and individual doctors are responding to. So I guess that's a comment that I can turn into a question, which is, how do we change that so that, that the right incentives are in place so that we don't have all of these, people trying to do the right thing, but ultimately having to do not necessarily the wrong thing, but act in the way that they're currently doing to be able to make money.
Yak, do you want to?
Well, the question I would ask back is, do we have a choice? And will it not solve itself if we don't solve it?
Yeah, we don't have a choice. It's like fee-for-service is one fundamental problem that has to go. You might want to do fee-for-service for surgeons, but maybe not, but you don't want to do fee-for-service for primary care anymore. We've got to find a different way to pay primary care.
And does that preserve primary care then?
It sure helps.
Yeah.
Primary care needs a steady sense of how much money they're going to make, so how many nurses, how many medical assistants, how many scribes they can hire in order to take care of the sickest people. And then they don't need to see people who have a cold that they can't do anything for anyway.
Before we wrap up, is that still looked at as a good profession? Do we have people, that look at that as a career profession they want to be into when you look back at the pipeline of talent and how they're deciding what they want to do with their lives? Because the more I've dug into this, the more that sounds like a miserable profession. And with all due respect to everybody who's out there, great. But
you mean all of medicine or primary care?
People who are day kind of working there and making the choices about how they want to spend their lives. This used to be an honorable, reasonably compensated, I won't say low stress, but nonetheless you sort of felt like you were one of the significant stakeholders in kind of keeping society together. Is that the case today when you look at the pipeline of talent and the...
Well, statistics, surveys of physicians, when you say, are you recommending that your children go into medicine? Fewer and fewer of them do it today. Yet every day I talk to, hear from, or lecture medical students and residents who are, and increasingly they are starting to realize that they can go into primary care again. We do need to refill that pipeline. We have this completely skewed ratio of way more specialists and too few primary care. So I think that there are lots and lots of young people out there who would go into medicine, go into nursing, go into PAs as they see hope for the system getting better.
Quick thought, Oliver, very fast.
Very fast. I think we're selecting in medical school entrance for people that love autonomy, that want to be independent, that want to do their own, make their own decisions. And when they're dissatisfied today, it's not because they're not making enough money. It's because there's an overwhelming system that's oppressing their freedom to do the right thing, and that's why they're dissatisfied. That's why they're telling their children not to go into medicine.
Quick final thought? No. Well, I want to thank Shannon Browlee, Oliver Kharraz, and David Yakimischak for a wonderful conversation that was far more human than I thought. You know, and I just need to confess that as we kind of talk about this, I do think there's an interesting debate. The Atlantic had a cover story last year called "The Robot Will See You Now," and you know, there is this debate about to what degree technology, basically doing diagnoses, finding ways to nudge people to do the right thing by following, you know, prescriptions and whatnot, that the world of sensors that we're going to move in, you know, I'm somebody who wants to charge into that future. I think it's great. I want to get rid of, you know, all of that variability, but I see that some of you really want to cling to human beings, and I guess we can be hopeful about that. So with that, thank you very much. Thank you.